Finals SAQ 79, Caesarean section for a Jehovah's Witness. You are asked to review a woman in the anaesthetic antenatal clinic. She is 30 weeks pregnant and is a Jehovah's Witness. She requires an elective Caesarean section at 39 weeks due to a low-lying placenta and a fibroid uterus. A. What specific issues should be discussed with this patient based on the history outlined above? Ensure no coercion from the family or fellow witnesses. Discuss what advice the patient has received from fellow witnesses, hospital liaison team, and other sources. Pre-operative optimization if necessary. Check current hemoglobin and hematinics. Liaise with hematologists if optimization is required, with iron, IV iron if rapid response is required, folate and erythropoietin. Explain the increased risk of bleeding due to fibroids and placenta previa. Explain the risk of untreated hemorrhage, such as mortality, major morbidity, prolonged ICU stay, prolonged ventilation and its complications, poor wound healing, infection, hysterectomy, and consequent difficulties with caring for the newborn. Explore specific wishes regarding blood products. The following are generally not acceptable to Jehovah's Witnesses: whole blood, red blood cells, plasma and platelet transfusion. The following are up to personal preferences: albumin, immunoglobulins, individual clotting factors, and anti-D. Do not make assumptions. Check the acceptability of all blood products and document clearly. Appreciate that there are no true blood alternatives. Jehovah's Witnesses website refers to blood substitutes. It is important that the woman understand that there are no true blood alternatives in existence. Explain techniques that can be employed to minimize risk of bleeding, such as elective cesarean delivery, consultant obstetrician and anesthetist involvement, regional anesthetic technique, possibility of the need for uterine artery catheters to be sited ready for deployment if excessive bleeding occurs, use of oxytocics to minimize postpartum hemorrhage, and tranexamic acid use if bleeding occurs. Explore the acceptability of cell salvage. Describe the process. It is up to the individual patient whether it complies with their beliefs and whether they can view the extracorporeal circuit as an extension of their own and uninterrupted. Explain the risk of cell salvage. Advanced decision. The patient may already have one. Ensure that it reflects the patient's wishes. A copy should be taken for inclusion in the patient's notes. Hospital-specific paperwork must be completed. Explain that the patient has the ability to change their mind. They are free to reverse their decision, including verbally at any time. However, in an emergency, the patient may not be capable or conscious to change their mind. No one else can change the patient's mind on her behalf in such a situation. B. Give the advantages and disadvantages of using intraoperative cell salvage during a cesarean section. Advantages include avoidance of risk of allogenic transfusion, such as ABO incompatibility, other transfusion reactions, bacterial, viral, or prion transmission, blood transfusion errors, and immune modulation and associated nosocomial infection. Cell salvage provides the immediate availability of blood. There is good value. Consumables cost slightly more than 1 unit of donated blood. Blood re-infused at room temperature, which reduces risk of hypothermia. Cell salvage is often acceptable to Jehovah's Witnesses. Cell salvage is useful in patients with atypical antibodies, whereby cross-match may be difficult to achieve. There are normal 2-3 DPG levels and thus oxygen delivery characteristics. Safe administration is possible with certain medications such as uterotonics and tranexamic acid. There have been no reported cases of amniotic fluid embolism attributed to cell salvage used in obstetrics. Disadvantages of cell salvage. In the case of rhesus-positive baby and rhesus-negative mother, there is risk of alloimmunization, which can be reduced by anti-D. Leukodepletion filter can release vasoactive substances, which can cause hypotension. Air embolism is a risk. There is risk of bacterial contamination. There is risk of electrolyte imbalances. No platelet or coagulation factors are transfused. Hence, cell salvage does not eliminate need for allogenic blood products in significant hemorrhage. Red cell lysis may occur due to skimming. This reduces the availability of whole red cells for reinfusion. and increases the quantity of free hemoglobin, which can lead to renal damage. Slow flow rate through the leukodepletion filter may not provide adequate blood volume for infusion during massive hemorrhage. The volume of salvage blood may be insufficient, and the patient may need to be transfused with allogenic blood in addition to salvage blood. There is risk of circulatory overload. Setup time may limit utility during a stat Caesarean section. There is high cost per use due to capital cost of cell salvage device, ongoing cost of disposables, and staff training costs. Staff training is necessary. It may be difficult to maintain staff competency if cell salvage is used infrequently. Overall, 44.6% pass rate. Additional information. Kindly refer to Finals SAQ 45 Blood Transfusion for additional information. With regards to cell salvage, Introduction. Cell salvage is a safe and effective tool in the management of significant intraoperative blood loss at Caesarean section. It offers an alternative or adjunct to allogenic blood transfusion during an obstetric hemorrhage and is recommended in guidelines published by AAGBI, Obstetric Anaesthetics Association, and NICE in UK. Its use is most cost-effective and beneficial for pregnant women with risk factors for postpartum hemorrhage. The Salvage group's randomized control trial found the routine use of ICS during Caesarean section did not significantly change the rate of post-op blood transfusion, and patients' recovery was clinically similar. In studies where the average volume of blood returned to the patient using ICS was larger, albeit in smaller non-randomized study population, the post-op HP was higher and hospital stay was shorter. This suggests that ICS is most beneficial in patients with risk factors for PPH during Caesarean section. Benefits were unclear in women who have lost less than 1 liter of blood. There have been no serious adverse events reported due to ICS use in pregnant women. ICS avoids the risk associated with donor blood transfusion and helps preserve donator blood stocks. Indications for ICS. Obstetric indications include invasive placentation, such as accreta, increta, and percreta, placenta previa, laparotomy for PPH or hemoperitoneum, previous PPH, fibroids larger than 8 cm or at hysterotomy site, emergency Caesarean section, repeat Caesarean section, 3 or more, multiple gestation, and classical Caesarean section. Medical indications include severe pre-op anemia, maternal coagulopathy, thrombocytopenia, declined allogenic transfusion such as in Jehovah's Witness, and problematic crossmatch. For surgery apart from Caesarean section, general indications for cell salvage include valve replacement, redo bypass grafting, major spine surgery, bilateral knee replacement, revision of hip replacement, radical retropubic prostatectomy, cystectomy, nephrectomy, giant basilar aneurysm operation, thoracic abdominal aortic aneurysm repair, abdominal aortic aneurysm repair, liver transplant, Jehovah's Witness, unexpected massive blood loss, and presence of red cell antibodies. Implementation of cell salvage should be considered when much smaller amounts of blood loss are anticipated, as the cost of administering allogenic blood has grown. Because of the difficulty associated with the accurate prediction of substantial blood loss and the possible need for allogenic transfusion, for the majority of cases it would be appropriate to set up the cell salvage device in a standby mode. Contraindications to intraoperative cell salvage includes biological contaminants such as feces, infective material, and bone chips. Note that urine and amniotic fluid are safe. Medical contaminants such as hemostatic agents. Examples of hemostatic agents include gel foam, Avitine, Surgicel, and Flosil. Other medical contaminants include medication not appropriate for IV administration. History of heparin-induced thrombocytopenia, malignancy due to theoretical concern of disseminating malignant cells, and homozygous sickle cell anemia, as the hypoxic conditions in the collecting reservoir can induce sickling. This diagram shows the cell salvage circuit. Blood is suctioned into a reservoir via a double lumen suction device that is immediately mixed with anticoagulant. The reservoir contents are filtered to remove debris and clots, and saline is added. Blood is then centrifuged. The heavier red blood cells are retained while lighter components spill over into the waste bag. Free hemoglobin, white blood cells, platelets, and clotting factors drain into a waste bag for disposal. Red blood cells are pumped into a bag and mixed with saline from where they can be infused into the patient. To minimize cell damage, blood is harvested from the surgical field using a large bore low-pressure suction system. A second suction can be placed prior to placental separation to reduce contamination with amniotic fluid and meconium. Bloody surgical swabs can be gently washed with isotonic saline in a sterile bowl and the fluid processed to optimize red cell yield. Salvage blood must be anticoagulated during collection, usually using heparinized saline. The decision to reinfuse collected blood is based on the estimated blood loss, preoperative HP, and clinical scenario. If there is more than 500 ml of blood in the reservoir, this is usually sufficient volume to allow processing and reinfusion. However, this volume is device dependent. Reinfusion should occur within 4 hours of blood collection. If reinfusion is considered, salvage blood is processed by differential centrifugation. Most cell salvage devices have a standard 170 to 200 micrometer filter. Microaggregate 40 micrometer filters and leukocyte depletion filters are also available, which are placed between the reinfusion bag and the patient. The leukocyte depletion filter binds DNA-containing cellular material to a polyethylene filter to improve the removal of bacterial, malignant, and amniotic components. They theoretically decrease contamination of salvage blood, but clinical studies are lacking, and they are associated with higher rates of adverse events such as hypotension. This table compares ICS collected blood and packed red blood cells. Temperature of ICS collected blood is at room temperature, while packed RBCs are at 1 to 10 degrees Celsius. Level of 2,3-DPG is normal in ICS collected blood and is decreased by up to 90% in packed red blood cells. Potassium levels are increased in packed red cells. Hematocrit may be higher in ICS collected blood, 50 to 80% compared to 60% in packed RBCs. Plasma, platelets, and clotting factors are minimal in both. There are no additives in ICS collected blood. Packed red blood cells may contain citrate, which can lead to citrate toxicity. These are my references. Thank you.